Good morning, everybody. Welcome to our next edition of Treat Live. My name is Kiriama Garcia Reyes. I am faculty here at Mount Sinai, and we have an incredible case, a very interesting case of biliary endoscopy for all of you today. Before we head into the room with Dr. Jenanan Vairavamurthy, my colleague, I would like to introduce, and we're very happy to have, Dr. Stuart Schroff. He is the Vice Chair of the Department of Radiology, as well as the Division Chief of Interventional Radiology at LA General Medical Center. So, Stu, if it's okay if I call you that, thank you for being here with us. How you doing?
Absolutely. Thanks for having me. It's a pleasure to be here. I'm looking forward to seeing what's going on.
Awesome. So before we go, I would like to thank everybody who supports this, all of you who are watching, who kind of watch our recorded videos, as well as all of our staff, my colleagues, and our patients. So without further ado, Jay, are you ready?
Oh, we're ready.
Okay.
Thanks, Stu, for joining. Appreciate it.
Absolutely.
So why don't we, so I just want to thank everyone in the room to help us with these cases, the nurses, the techs, the anesthesiologists, to get these cases going. So I'm going to have Toyin introduce the case. She's one of our fellows, or I guess residents, right?
Yeah, you're right.
So if we could show her slides, pull up her slides, please.
Yeah. All right, so today we have a 73-year-old female with a history of hypertension. She had had a recent admission for pneumonia, a prior cholecystectomy back in 2023, a newly diagnosed benign liver mass. She had presented with malaise, right-sided pain, right-sided abdominal pain, vomiting for 1 day. She got an ultrasound and an x-ray which showed this right lower lobe opacity and a new perihepatic collection, and there was a concern for empyema and a perihepatic abscess. So we were consulted for further evaluation. So on clinical evaluation, her temperature was 100 degrees Fahrenheit, blood pressure is 133/79. She was tachy at 111, and her respiratory rate was 18. She did have right upper quadrant pain, and she was noted to be an AFib with RVR at the time. As we discussed, her medical and surgical history, she did have hypertension, the prior cholecystectomy back in the Dominican Republic, family history non-contributory, and she was only on atenolol and omeprazole at the time. So here we have her ultrasound that she came in with, and we see this heterogeneous collection that measures up to about 10 centimeters and was compatible with an abscess, and we can see calcifications within that stone which are suspicious for dropped stones. So for her hospital course, we placed the 12 French test drain in the empyema, and then she underwent a TTE because of the new AFib with RVR, and she was noted to have this extra cardiac cyst compressing the right atrium that was consistent with the hepatic abscess that we knew of, and so we placed a 14 French hepatic abscess drain on the 15th. So we can play through this. We see this big empyema, and we also see the perihepatic vein.
Yeah.
Perfect. You can see this is our drain, and you could see some stones on this adjacent to where our drain is. And we can go to the next slide. And we have a still for you that's showing at least 4 of the stones, drop stones, that were likely the nidus of infection. So after this, the patient did well. She was discharged on a course of antibiotics. She underwent upsizing of the drain to 16 French, and this is to allow for tract maturation so that we can use Spyglass for removal. And then she underwent a staged endoscopic stone retrieval earlier this month. So again, for our assessment and plan, this is a 73-year-old female, history of hypertension and cholecystectomy, had presented with malaise, right upper quadrant pain, and found to have this hepatic abscess and empyema, likely second to the drop stones. This patient was not a surgical candidate at the time because she was very sick, and as a result, we decided to proceed with endoscopic stone retrieval.
Thanks, Toyin, for going through that. Again, this is a challenging problem. When you have drop stones, they often drop into very tight spaces that are not operable surgically. So I think this is a great technique to help patients in that situation and condition. We got a little bit of a head start when we got in.
So can we go to the fluoro images? So we started with a cone beam CT. And Jay, why did you decide?
Yeah, I'd like, once we start the case with the scope, you kind of can lose track of where you are and how you started. So I wanted to get a cone beam to start to see exactly where the drain was with respect to the space and with how many stones you could see. And on this prior CT, we kind of knew what we were getting ourselves into. There's 5 stones left. The measurements are important too, so you want to access that can accommodate the stone size, and they're ranging in the 6 to 8 millimeter size, which is pretty big for stone. So the pre-procedure cone beam is very helpful for that. And then we did spot films as well, just to confirm what we were seeing on cone beam. And you can appreciate the radiopaque stones. They're faint, but you can definitely see the stones there.
Yeah, Jay. So we're here. You've already treated this patient, retrieved some of these stones. Can you talk a little bit about the setup for this case? It seems like you placed a drain. How long do you wait? Just take us through a little bit of that.
Yeah, I think anytime you want to use the Spyglass in general, you should start off with like a 12 French drain, even if you're just planning on doing a scope without any therapy. So for this patient, we wanted to go for at least a 12 French, but based on the CT, we kind of knew that we had to get something bigger. And so I started with what I thought was kind but yet effective, which was a 14 French drain. Left that in for about 4 weeks, let the infection cool down. We got the abscess down to basically nothing. Output was minimal. And then we upsized her to 16. You could have gone 18 there, but we just had a 16 French available. And then after that, we waited another 4 weeks for that tract to really mature. The most important thing is waiting. Once you have a mature tract, it's a lot more easy to navigate. If you rush it, you might not be able to get a good stable sheath in to manipulate the camera well and get into tight space as well. So it was a lot of communication with the patient and her family. I mean, she has a life to live, and living with the drains can sometimes be challenging, but I explained to her the exact approach and how long this was going to take, and how this might save her from a surgery that could be really complex or a really bad infection. And she was on board with all that. And it's really important to message that from the beginning so people do not get frustrated with having a drain for a long time. So once we had the 16 French drain in for a bit, our first procedure, we were able to upsize, and I thought I could get away with the 24 French dilator alone because the largest stone was about 6 to 7 millimeters. We got 4 stones out and we were going for a bit, but some of the stones we just could not get through our tract well. So at that point I took a pause and decided to bring her back to go up to 30 French, which is what we're doing today.
So Stuart, how do you guys approach these cases in California?
So I actually haven't done Spyglass outside of a lumen, so to speak. So I mean, right now you're pretty much doing laparoscopic surgery, right? I mean, you're getting into the peritoneal cavity, and which is awesome. As far as like upsizing, Jay and I trained together. We probably started doing Spyglass together, and we have a similar approach to kind of starting with the 12 and then going up from there. And one of the things I love about Spyglass is I feel like every time I use Spyglass, it kind of tells me something I didn't know before based on just being able to see instead of doing the two-dimensional stuff. When you guys did the first case, you drained the abscess, right? That was the first thing. You drained the abscess, cooled everything down. So when you went back, did you do anything to create space? I mean, I'd imagine there's no space in there, right? When they do this laparoscopically, they're insulating with CO2, right, to create space. And what did you guys do? Were you able just to jam stuff in there and snake around and find them?
I actually did not want to put too much saline in there to distend the cavity, just because the sheath is pretty rigid and the cameras can go into weird angles. So if you get the camera pointing a certain way, your sheath may not track that way anyway. So I wanted the space to be a little bit more controllable, where I could see the stone and have a rigid sheath in place to be able to get a device in, because if the camera's going at a 90-degree angle, it's hard to get a device to track.
So then how did you get this is, I'm going to explain how you got up to 30 French.
Yeah, so
if we could
anybody
show this,
interested in this, I think this kit is really important. Shout out to colleague Raj Patel, who taught me about these back in the day. This is the renal Amplatzer dilator set. It's actually a ureter-based set to actually get stones out that way. And as you can see, it goes from 12 to 30 French. The 30 French is in the patient right now. And the good thing about the larger size is that it has this almost like a peel-away sheath on top, but it's not peel-away.
It has a bevel, right?
And it has a bevel for direction. And so it's very rigid, so it gives you good support to put the camera through and the device through. And the dilator set makes it easy to distend your track a little bit.
So then once you got the 30 French in, so just I don't know if you can explain what they see on this image, so.
Yeah, can you see the fluoro spot image right now?
Yeah.
Yeah.
So patient came in, they had a 16 French drain in after the last case. We cut the hub of that. I put a Amplatz wire through the 16 French drain, and then put a 10 French sheath over that so I can get a buddy wire in. So I have a 01880 Nitrex alongside an 035 Amplatz, and then I took that sheath out, and over the Amplatz alone, we dilated using that set, and I have the 30 French beveled sheath from that dilator kit in. It's beveled in a way that optimizes, if you can tell on that image, it's kind of pointing towards the stones as opposed to blocking us. There is a little bit of nuance in terms of getting comfortable putting a sheath that large into a tight space. It does feel like you're at first doing something that you shouldn't be doing, but she tolerated it the first time and she'll do fine this time as well. And so, yeah, now we have the camera in, and
All right, Jay,
maybe I can go
could
to the
we
live
see
feed.
like the axial from the Dyna CT or something? I'm just curious at how much
I'm
space.
trying to
Like,
show that.
Well, we're
Give us
finding
one
that
sec.
cone beam CT. Let's talk a little bit. So we talked about track maturation, but it seems like, angle here is really
Yep.
important. So when you're placing that, talk a little bit about when you're placing that first drain, kind of what are you looking and what are you trying to target?
Oh yeah, that's a very good point. The most important thing is making sure the drain is going towards the stones. You don't want to just pick a spot where it's going to float and not end up by the stones. We're very intentional during drain placement of targeting the stones, using a wire and catheter to get next to the stones and leaving the pigtail as close to the stones as possible. Because once everything decompresses, you just have a drain in space, and that would be a very, very challenging thing to navigate. So once the pigtail was formed right by the stones, I knew that we had a good chance of getting these out. If there's a stone in a different type of space, you would probably have to get a different drain in, to be honest. You
Yeah.
don't have that much flexibility of navigating
Yeah.
these
Can you guys see the Dyna
spaces.
CT or no?
Can we scroll through
Yeah, we
that
can.
cone beam CT, please?
Can you scroll through it, the cone beam?
Yeah, there you go.
There you go. So go down. Yeah, scroll down. So you can see the pigtail.
See the
It's-
pigtail and
It's kind of wrapped around the stones, right?
then
So
scroll back up. Stop a
Keep
little
going
bit
up.
higher.
keep going up.
Other way.
Other up. Yep. Keep going. So you can see the stones there.
There's stones. You see those, and you can
Yep,
see how
yep.
tight that space is. It's basically
Yep.
liver and then intercostal space right there. So, and you could see 5 stones there, which is it's actually very helpful to really delineate the
Yeah.
problem. Instead of just, I would not go into these cases and just think, oh, let's put the camera in and look around and see what we find. Maybe when you're first starting, but the camera has a lot of limitations if you don't know exactly what space you're in and what you're targeting.
So you want to talk a little bit about the camera? So we have the Spyglass,
Yeah.
right, which we put through. So
The Spyglass itself, I don't know, can you see this?
Yes,
It
we
has
can.
2 articulating ports here. It has a lock mechanism, so once you're in a spot that you want, you can lock it. It also has a side port that fits a 1.2 millimeter working channel here, so a 3 French device. We currently have a device through it. You can put a wire through here. You can put a snare. You can put a microcatheter if you're going to do an advanced technique, and you can also put a lithotripsy device through here, which we have available to us. We are prepared to do lithotripsy today. It's more of a backup if we can't snare it out. I'd like to leave the stones intact if possible to not create a situation where I have to chase something else. The Spyglass is not that long. It's really easy to navigate.
So it's made for IR, right?
It's made for IR. It's made for us,
Yeah.
which is nice. And again, it can go through a 12 French sheath. So for diagnostic purposes, I would definitely start off with a 12 French drain.
What's the actual size
Nice.
of the Spyglass?
10.2.
10 French or
10.2.
10.2.
Yeah,
Yeah.
within the
11
10.2.
French is the minimum sheath. The minimum you need is 11 French sheath to go through. Little yellow
Okay.
guy.
What we did is we sort of, you want to,
Yeah, we can you guys see our feed there?
So to
Yeah.
the left, we can see the feed of the Spyglass, and to the right, we're seeing your fluoro image. So I think we're
So do
pretty
you see
well
all
set
these
up.
stones there?
Yes.
These are all stones.
Rip it and rip it.
So
Looks
these
like-
are pigmented stones related to bile, and Rahul is a master and putting that in. You see
So
he
we-
grabbed it,
we got it.
and so now I'm gonna pull back everything, and you see now I think this is where we're getting stuck. You still have it?
I still have it.
All right, pulling back. Oh, do you see? Can you go to the camera feed up here? So that,
Please drop it. It's easier.
Yeah, now
Oh.
it is.
Oh, you
Oh,
only,
that's big.
You see,
no, yeah, right here.
Yeah.
Yeah, these are pretty large, which is
I'm gonna pull back.
So
little bit.
Stu, you commented on the size. You're like saying, "Oh wow, it's big." So talk to us a little bit about the usual size of these stones and kind of what you're comfortable taking
good,
out
right? Yeah.
percutaneously.
Yeah, so I think the I don't know if you meant that for Stu or me, but 6
Or Stu, but
millimeters
you
is
can
kind
answer.
of, yeah, 6 millimeters is a good cutoff to think of like I can get these stones. Once the basket itself, the one we're using, goes up to 12 millimeters. The problem is when you're in a tight space, getting the basket to curve around a stone easily is a little bit challenging, but luckily I have Rahul Patel here.
It doesn't really.
It doesn't really articulate as one
Yeah.
around the stone. I don't know if you guys could see. He's let me see if I can get it better.
Yeah, we can see the feed. If you can show us the basket
Okay.
when you bring it out of the patient, just so we can have an idea.
Yeah.
Oh, I
So
don't
it
know
seems
if
like you're
that's-
trying to get around that
Yeah.
stone. Go ahead, Stu.
We're trying to
As
get
far
it.
as size goes, I don't really think about size. We just get in, we see what we see, and then we deal with it. And if it's too big, we try to crush it. But usually we try brute force to get it out, and then that doesn't work, then we try to crush it.
Yeah, I don't think we're.
Yeah, see, maybe we should go with the snare here, maybe.
Yeah, so we were prepared for this. Or when I say we, I mean Jay was prepared for this. Yeah.
But the basket is a little bit challenging.
Yeah, because it doesn't have any like spin to it, right? Like it can't
Yeah.
really.
And a very important aspect of this is visualization. And you can get the Spyglass and not get the saline pump. I would advise against that, because if you're just injecting saline periodically to see, it's very challenging. Try doing it that way.
I think we're not getting anywhere with this.
Yeah.
Yeah. Okay.
I mean,
So
here it looks like we have actually great visualization of a couple of those stones. So it's more
yeah,
kind
we
of
just
the
can't really.
flexibility of the device. Yeah.
You have the snare, right? Because you're sort of limited by this thing. I was seeing if I could like jam it up against the cavity wall and get around it.
See if they would move. Yeah.
Yeah, but they're not. They're kind of fixed, right?
So what are your options now?
Well, there's other types of baskets. Do we have the? Can you bring that one over? We have another bigger snare that we could try.
I know.
It's very
it's
close.
frustrating. But
I'm going to try a different basket that's a little bit bigger. This one goes up to 15.
okay, so we're gonna take this one out just so you can
This one
show
goes
you
up to
guys.
15.
So
Yeah,
I don't know if
you want to show them that one?
yeah, if you want to see this one.
Can we
Yep.
see what's on the
We'll get a
table,
different
please?
So let me just get a different colored towel so it's easier to see. All right, so I don't know if can you guys see the basket?
Yes.
Oh, yeah,
Yes. Now we
yeah,
can.
yeah.
It's very
Yep.
yes.
Very
so I'll
faint.
show you the handle.
Perfect.
So this
There
is,
we can see it.
So this is the handle, and so when you push it forward, it closes, and you push it forward back, it opens. It has torque here, but not a ton of torque.
This one's huge.
So we're gonna try the different basket. So I'm gonna just show this one, so you can see the difference in size between these two baskets, right? So I don't know if you can see the difference, but it's bigger.
Can we zoom in?
It's a little bit more sturdy. It's a bit sturdier.
Yeah, we can see it now.
And
Yeah.
the only challenge is that we had to get it from endoscopy because it's not really designed for
Spyglass.
this yet, so it's very long.
So you want to close it? Let's see. Does it fit through here?
Yeah.
Oh yeah, there you go.
So
Three
while we're
stones.
loading that up, Jay, let's talk a little bit about drop gallstones. Is this something you see pretty commonly?
Drop gallstones can happen up to 10% of cases, which is a lot more than you would expect. It's usually
Do you see it?
I feel like some type of perforation during laparoscopic removal,
Okay.
and some are benign.
open it?
You know, people have them and they do okay. I'm sure we've all read CTs in our radiology residency days of a drop stone and thought it was cool. But an infection can be really, really challenging. I had another patient with this very similar situation that his infection was coming out through his lap scar. It was that bad, and
Wow. Yeah.
they took him to a big surgery, opened him up. It still couldn't find the stones.
See, there we go. So now we're kind of open. You can kind of see the fluoro images.
Yeah, we've
Grab the other
definitely
wire.
been asked at biopsy. You know, sometimes they kind of fall outside the liver and they create this little cavity there, and
I don't.
sometimes, you know, people miss it. So just be aware if you see a calcification in the setting, extrahepatic in the setting of a cholecystectomy.
Yeah, and you know the last one I did in this scenario, he grew out Klebsiella, so it really helped with antibiotic treatment too, and he did well.
Yeah.
I'm not sure you have to go after every drop stone. I mean, if some, like I said, are okay just being left alone, but if it's causing a big infection, then yeah. Should we pull back a little bit, maybe?
You know, fluoro or
So, you know,
Sorry,
we're
can you just
seeing the fluoro and the spyglass. Like, just talk to us. Is one of you managing the scope and the other one the
Yeah, I'm doing the scope
basket,
right
or-
now.
Yeah.
And I'm trying to angle him towards things a little bit more. And Rahul is using the scope. And problem is
Ooh.
Close.
Yeah.
close. Yeah.
Stu and I are really rooting for you here.
No, kind of want to scrub.
thanks, team.
I got the wire.
Let me push that in a little bit more.
Stu, are you going to say something?
I'm just leaving this.
No, I said I wanted to scrub.
Oh, yeah.
I'm wondering, you have a 30 French sheath in there. I started thinking about like other devices. I mean, could you put like a filter retrieval forceps adjacent or is that too tight? It's got to be
Yeah.
close. You're pointed right at the stones.
No,
Uh,
admittedly, I tried that on the last one, and it just does not grab this. You can't get it around the stone well. Worth it
Oh.
to try again.
I think maybe if you
if
back
you're
out the,
close.
See?
yeah,
Back up
I
the
think the
sheet.
sheath
And
is
then my
kind
other
of
thought
close
was
here.
Okay.
like myocardial biopsy forceps. They're not big enough, but I wonder if it would like grab the stone, kind of, depending on how hard they are. I don't know. Just thinking of all the different.
Yeah, I think the forceps I tried.
I'm just trying to jam it up there, right, and see if you
Yeah.
get lucky.
Worth trying again.
It's
Just a
clearly
matter of
around,
moving.
right? Like it's just, I know, just super frustrating.
but get my scope a little closer.
All right,
Be a little support. Problem is if you start moving your sheath too
So
much.
Stu, while they're working here, talk to us a little bit about the biliary work that you do and,
You're gonna
and
ride
which other
you're
scenarios
gonna
are
ride
you
the-
using Spyglass in?
you gonna ride the scope?
Yeah.
Or the
So we're
snare,
using
sorry.
Spyglass more and more now. Kind of as I mentioned earlier, it was like, as we started using it, it was kind of slow. And then I think we realized that anything that wasn't quite straightforward in the biliary tree almost benefited from putting the scope in. So we've had patients who, obviously stones,
Let me try to turn it
strictures,
this way.
malignancies,
There we
big
go. There we go.
biopsies.
Yeah.
We found that doing image guided or endoscopy guided, I guess,
Let's try
biopsies
the
as
tri-loop.
opposed to the usual like
Yeah, right.
jam and grab technique of fluoro has been better. We've actually
Try to see if I can.
some of our
Really trying
patients
to
have
grab
a
it.
lot
Yeah.
of stones, a lot of stones, and it becomes.
It just doesn't want to go around, right?
Yeah.
I started wondering, like, at what
Look
point
promising there.
what's our end goal, right? It's like we can stick a scope and we start clearing out stones, but then you never get them all. Like some of these patients, you can never get them all out. And then at what point, like, what are we doing, right? We can get some of them out, but if we're not clearing them entirely, so getting cholangitic,
Such a
like,
good view right
what's
there
the
too.
stopping point?
doesn't
It
wanna-
kind of opens up these abilities that we didn't used to have. And
It's like collapsing right around it.
kind of
Yeah.
applied this to more and more cases. And now we're starting to get surgery involved. So we're kind of being like, okay, well, we're going to clear out the stones that we can clear out and almost like we'll do this part, you do that part sort of thing, get it to a point where they can do some sort of resection if they need to, leaving kind of the part that we treated alone.
Yeah, just not going around, right?
Yeah.
It's been
Try the
we just kind of start seeing what we're doing now more. And for me, it's been just really great
Gonna
being
move on?
able to
Yeah.
Okay.
see what that filling defect
So I'll leave the
is. Is
camera
it
in,
granulation tissue?
and then we'll
Is
put
it
the
mass? Is it stone?
Just leave that in. Just leave it in.
Yeah.
Kind of just don't know.
I think
It's
that's a
okay.
good point. There's so
Yeah.
many patients out there that we do routine chole tube checks and
Pull
chains
it
on
back.
that just have stones that they're not good operative candidates, and we should reconsider what our options that we offer them.
So now we're gonna move on. Try sort of one of more standard IR snare, right?
Oh, sorry.
Yeah, I like that idea.
See if we can spin our way.
Did we try
What
this
size
smaller
is
one?
this there?
This is the big one.
This is the big boy.
The it might be too big actually.
Yeah.
'Cause it's not really.
So we're right on one there.
Yeah.
Not opening.
Yeah, it's just not.
It's too big.
What about a boba straw?
Should we
Stick a
try
boba
this?
straw down there and suck on it. It'll come out.
Yeah.
24
Exactly.
French aspiration device.
I don't think we're going down that road. Oh, I got your.
You got one?
No, I got yours.
Okay.
The scope.
Huh.
You wanna come up?
Can
a
we
little?
get is there a 915 tri
Yeah,
loop?
there is. You wanna go up a
Yeah.
little bit though?
Yeah.
I'll just keep trying while he
Yeah,
gets.
yeah, until he gets it.
They're right
one is
there,
available.
team.
I know. I'm gonna go up a little bit with the snare.
Push it forward.
Yeah.
Let me push my camera forward too.
It's funny. The first one we got like
Quickly.
quickly,
Immediately.
and then like, it feels like it's around, right?
Yeah.
And I mean, this
But
is
it's
like
just-
perfectly positioned that, your access. Imagine if you don't perfectly position it, right?
Can you,
It would
can
make
you go
it
up a little bit with the
even
catheter,
more.
snare catheter?
Yeah.
So Jay, they don't seem very mobile. Are they
Yeah.
moving around, or are they not moving around?
Some of them are. Yeah, some of them are. As we're
Finagling.
finagling. Yeah.
Yeah, it's
Good point. So,
a little frustrating when
wondering,
you
are
see
they-
them and you have a snare next to them.
Are they scarred in?
Yeah, that's what I'm wondering. Are they
Like
adherent
soft, yeah.
somehow?
It really does look like
Very
it,
well
doesn't it?
could be. Do you have something?
No, I think it's just tied into a knot.
No, you're gonna take it out real quick. Yeah.
Yeah. I think it's just
Which
too
is
big.
Yeah, I
Stu,
mean, it's a
why I
good
like
point
your.
about-
Oh, go ahead.
She had a really bad infection before, and there's some people that just kind of have these. How many? Is it okay to leave a couple behind or do you need to escalate constantly? It's a tough question.
And I think that's a
but-
point Stu was making when you were working. You know, a lot of these patients with biliary stones have so many of them. So, you know, at what point,
Yeah.
you know, is how many do you need to take
can't
out?
get-
What's your stopping point?
Yeah, I don't have a great answer for you in terms of like, is it okay if I leave a few behind? My intuition is to try my best to get all of them, and if not, you know,
Yeah.
I have a good relationship with her and her family, and if we can get most of them out, she's feeling a lot better now. She would definitely follow up, and we would definitely be able to navigate things for her as needed.
I just don't see anything on the scope anywhere. Yeah.
Let me just. There we
Is
go,
this the
right here.
smaller
Can you
snare?
get that one?
Yeah.
So close.
Hey, can you push the
Ooh.
catheter, the snare
Do you
up?
have one?
No.
Oh, okay.
Jay.
Yeah.
I guess that's my question. Like, are they even? I don't have a good perception of whether they're even moving.
They're moving a little bit. They're not
Okay.
completely adherent.
I guess you gotta bring the catheter back a little bit. You're too far.
Oh, sorry.
Yeah.
Yeah, they're
Can you bring it back a little bit more? Sorry.
gonna form it in this. Oh, there you go.
Yeah.
They're moving a little bit as he pushes. It's just a really tight space at this point.
I wonder if, you know, Stu mentioned this before, but if some type of
That's like in-
forceps just
yeah.
to get him off the wall,
You push it
Or-
forward.
Oh, yeah.
Sorry.
get him loose.
Yeah. You have back tension.
Yeah, it
on?
looks
You're
like
trying
they're
to collapse it?
twitching.
Okay.
Yeah.
They're not rolling. They're just kind of like shaking
Correct.
as
Yeah.
you're pushing on it.
No, we can
Like
try.
that should be on it, right? Like.
Yeah.
So Stu,
should
it seems
be.
like you've used the Spyglass a lot. What's
I'm
the
grabbing a
learning curve
Spyglass
like?
if you push,
Oh, are you?
push the catheter up.
I'm not sure I've used it a lot. I've used it a bunch. I don't know. I never consider myself an expert for anything, but I think the biggest learning curve is the manipulation of it. And we have, when I started doing this with Jay and others, there was a GI guy that we worked a lot with, and he would come in and help us, and watching him manipulate the camera was insane. It's like us with wires, right? And he was just like all over the place, and I'm going to go here and I'm going to go there, and getting oriented
Do you
to
think I'm
like
too on that one?
I think
Yeah,
the sheath is too
big
far on the
deal.
stone, right?
Okay.
um,
So I'm gonna pull this back.
I
a little
rely
bit.
a lot on, less so now, but still on the fluoro. Like, where am I?
Mhm.
Right? Like, I'm looking at something.
Yeah.
Where am I?
Yeah.
All right, I'm gonna push my camera forward a little bit.
And also Jay's comments about the flushing. Initially, we didn't have the pump for the flushing, and what we ended up using was like a IV pressure bag infusion kind of situation where we plug that into the top and make like a poor man's pump, and then have like a big syringe teed
Oh,
into
there
it,
we
so every
go.
so often we could
Right.
increase the
Yeah, right
flush.
there.
And that works pretty well, but having the
So,
pump is better.
Challenge is getting
Yep.
this thing. I'm
And
gonna.
then-
You're gonna push the
And
snare.
what really kind of is when we started doing the lithotripsy stuff, that was so much fun. It was just like, oh, it's like a video game, and we're making differences. But really the navigation of it, kind of like ice for tips, right? It's like,
Yeah.
okay, I've got this new thing, I can see stuff, but what am I looking at, and how do I manipulate it? And it still tend to lock it. Like, I'll get
Feel
it
like
into
it's-
scope
you're on-
into a
it
position,
feels like
a
you're on something.
configuration, and then lock it, and
Yeah.
then twist it
And then
around
I should
more like I would
snare you down. Sorry, I didn't advance my catheter in time.
than
Anyway.
a scope, and that's probably not.
See, it's pushing it.
I
You
could
can
probably
see
do
it
better
real
at
time
that.
moving
I get
on
more
fluoro.
facile with
You see?
maneuvering the camera than just relying on
It
it
won't
like
come
a
in anymore.
catheter.
It's not. I can't. It's locked in something, but I don't know
Oh,
what.
really? Maybe we have something. Let's see.
Do I have
Is it
your-
on the camera?
No, it can't be.
It's okay. I feel like we have
That looks
something.
promising.
Yeah, we got one.
You got
But I
one.
still-
We got one. Nice. But it's weird. There's like
No,
radio.
There's
I
more.
guess there's some that are not radio pay.
There's more.
So we got
Okay.
another one.
Maybe. Two
How
down.
are
Two
those,
down.
are those
12 more to
crumbly?
go.
What are they? What? Jay,
No,
are those
they're-
crumbly?
they're-
Are
they're
they
s-
soft?
No,
No.
I'm squeezing it between my fingers. I'm not trying to crush. I mean,
Is it
Toyin's stronger
smushy?
than
Is
I
it
am, so let's see if she can.
No,
No,
it's
they're
like
they're rocks.
They're rocks.
the rocks?
Yeah. They're
You're gonna put the scope in first.
oh, yeah. The
My mind's kind of
cholesterol
going to like,
stones.
there's still a bunch in there. I suspect there's a decent chance you're not getting every single one that comes out. Then I start thinking, what are
Have
you going
faith,
to do?
Stu. Have faith.
I have faith. I have faith.
No,
I'm
but
just
I
like,
I like where Stu is going, like, future planning.
Yeah.
So Stu, go ahead.
I'm like, do you try to sterilize the area? Like, if you're going to leave something behind, do you try to sterilize it somehow, or I don't know
I
what
can
that
still
looks
see
like.
5 radiofake stones there.
Sorry, I think you pulled.
Do you have something?
Yeah, you have it. Or you pulled it
I
from
got
the.
something.
Yes, you do. You have the one that was at the top. I see it in
Yeah.
your.
No, it
came out?
Yeah, it came off.
Oh, that was so good.
So let's actually, well, I might push it forward.
Okay.
You want to try to grab
Sorry,
it in
Stu.
the
I didn't mean
shape
to
itself?
interrupt you. I just got excited.
No, no.
So yeah, so you're saying sterilizing
I'll
the
push
area.
the
How
camera
so? Like,
forward.
are you talking about like a little infusing something?
I don't even know, but like,
Yeah.
you know,
It seems like it's a
where I
well-formed
kind of-
cavity by this point, right?
right. I mean, could you sclerose it? Could you drop some alcohol in there? Is that safe? Could you, I don't know, doxy? I don't know. Something that's, I think the natural
You gotta bring the
course,
catheter up, right?
Oh, yeah, yeah.
like Jay said, there's a lot of drop stones out there, right? And not every patient with a drop stone ends up with a big abscess. So there is, I suspect, the usual natural history for most of these is they get absorbed and the body deals with them. This patient and other patients
Oh,
obviously
you got something there.
It's close, right? It's
that doesn't always
pulling on
happen.
it.
They're moving around a lot now.
Yeah.
And
I
this,
think we made a little bit of room.
it kind of goes back to what I've been thinking about with our biliary stones. It's like when somebody's chock full of stones and we get a lot of them out, but we don't get all of them
Turn
out.
my.
Nothing's moving around.
Can you turn the
Yeah.
sheath that way, like the
Bevel?
bevel? Yeah.
What do we do? And some of our patients who have these stones, they're probably, they drain sort of, but they're probably
catheter
they get recurrent cholangitis and they keep getting infections and stuff like that. And in the biliary tree, you can't sterilize that, but here maybe you could, or maybe it's gonna heal, or I think what could you do to
Yeah.
You just push the
encourage
catheter.
it to heal and not get infected again?
Should we try the bigger snare again now that there's more space, or is that
Is there
full
more
Zarin?
space?
Yeah, there's not that much more space.
Are you using the snare catheter or are you using a directional?
Just a snare
Snare
catheter. The snare
Diagnostic
catheter has a little bit of
catheter.
an angle to it.
Yeah, yeah.
We're using just the.
Yeah. I don't even know if we're around
I
anything.
mean, the question, I guess, coming back to what you guys were talking about, is if we can't get all of them, how long do we leave it drain in? And do we trial her without? Do we take enough out that there's not going to be an infection? Or do we?
Yeah, I don't know the answer to that. I don't think.
Yeah.
Yeah.
Yeah, I like the idea of maybe putting some doxy in there. Something. I don't know about alcohol because I don't know what that's gonna do.
Yeah.
I agree. It's a little bit. Doxy's pretty. Seems pretty.
Pretty benign, right?
Alcohol is
Yeah.
like.
So at this specific moment, it seems like you're guiding yourself mostly by the fluoro image, correct?
They were moving a little bit, and also, do
Yeah.
I have? Let me go back to.
Gonna unlock
All right,
this.
here we go. We're good there. There's one. Yeah. Oh, you're kind of just like right on
Touching
it.
it, right?
Yeah. It's crazy.
You want to bring the catheter? Maybe see if I have it. If I pin the.
Ooh, it wants to
Nah.
come.
It's like.
I feel like it's right there. Come here. Go to your home.
in your home.
Go to your
And then I guess Jay just,
I'm
you
like,
know,
it's like
we-
in the sheath right now. We're in the
Yeah.
sheath here. You see?
It's bouncing around.
Like- Oh, you got it. You got it.
oh,
Almost.
Almost.
Should we put like a balloon in alongside and
Just sweep it in.
swope
Oh,
it
did
in?
I think
there?
you just blew it in when you stepped the pedal.
Oh my god.
You're gonna push the thing up, the catheter, snare catheter up.
so Jay, going back a little bit to the
Oh.
setup of the case. So
We
are
wanna go
these
over it, right?
patients, was she on antibiotics with the drain in or
Yeah.
once?
Yeah.
Okay.
Patient was on long-term antibiotics for like 2 weeks,
Okay.
14-day course.
You're gonna bring the scope up because I can't see anything. Right?
Yeah, give me 1 second, Karma, sorry.
No, you concentrate.
And I sent her home on antibiotics after the last case too for 5 days.
But she's not on chronic antibiotics.
She's not on chronic anymore.
No.
Like once the empyema the
abscess.
abscess went away, she got a lot better.
I'm gonna bring the catheter up to see if we
Feel something. It's like getting on it and then stopping.
push the catheter up, the snare catheter up.
So Stu,
That's a
kind of
good
take
idea.
us, you've mentioned a lot of,
Should we try
you
to grab
know,
some of these?
create
The forceps
fun
or
part,
something?
getting
Yeah.
creative. What
Huh?
can we
Do you
do
wanna try the
next? So
forceps? I mean, they're right there.
Yeah.
you talked about forceps. Anything else you think it's worth trying here?
We're gonna try
Um,
forceps.
I mean, I'm thinking
Andrew,
of like just stuff to grab with,
forceps?
and that's kind of our go-to.
The
I mean,
endobronchial
all the snares,
forceps.
obviously.
Endobronchial
I
forceps?
think he has them.
The forceps.
No, these are small
come to mind.
ones.
We
That's
kind
the
of
only
Oh,
use
yeah,
a
yeah.
lot.
Yeah, we can't use the
So,
Limo
Yeah,
ones.
yeah.
and we use the endobronchial biopsy devices, and there's some GI actual, they're not endobronchial, myocardial biopsy devices we've used a lot of. And then
How big do these go?
GE has bigger biopsy devices that are similar that we've
Yeah,
used
see,
before.
it's very small.
Yeah, I don't know
With
if that's
this,
gonna
I'm
work.
also thinking
Yeah, it's too small.
even something which is crazy and super
Oh
expensive.
yeah, that's never gonna work.
That's not gonna work.
Army, like if you just
Um,
stuck a big, we need a 30
Do we have
sheet
those
and
endobronchial
stuck a
biopsy?
24 French Inari down there.
They're in the
Suck
closet.
Okay.
it.
Yeah,
Yeah.
okay. Aspiration
Uh,
devices.
Yeah, I don't know. Expensive.
I mean, I don't know if that would
But,
work for this size stone, though, right? Like,
yeah.
I don't know, even if you
Also,
log off
there's
it, you can hold it up.
there's continuous communication like with the outside space here, so I'll never be able to create a vacuum. There's no valve on this peel away.
Well, if you put a
try this.
if you put
So
a flow treater in there, you would have a vacuum on the flow treater. Or
right, it would suck the air from the external world because there's
Oh, I see.
no hemostatic valve on the back end here.
Gotcha. Yep.
So if you
Um,
aspirate it, it's just gonna.
So
you
we're
know,
back
the-
to the original.
Whoa, we're just waiting for other forceps right now.
Yeah. Yeah, just trying one of the original. Yeah.
It's in our sheath. This does not
Is
want to
it-
come
right
all the
there.
way out.
Is it stuck on the camera? Is the camera blocking it?
It's not.
You're gonna come down a little bit with the
Not
camera.
stuck, but like if you pull everything back,
Oh.
Oh, we're doing that, Stu.
Oh,
We're
oh.
doing it.
Stu.
Smart move.
back together again, Jay.
It's like you're scrubbed in,
back.
Stu.
We're so back. Oh, it fell.
Oh,
Oh,
we got a couple- we got a couple of them.
We got a couple here, guys. We got two more. We got two more.
I feel like I'm with my child at the claw machine.
That's the nicest thing you've ever said to me.
I gotta.
I would love to be your family member officially.
My son gets so excited when he gets to the claw machine. He gets two
The
prizes.
claw.
Can
Why
we
are there still
see?
5 radiopaque
Can
things
we-
I
on
don't think it's gonna work
fluoro?
that way.
Toyin, can we see them?
Why is
Yes, of
why
Toyin,
is
course.
took them
fluoro
away.
showing me
I can
5
see you
stones
for
still?
it. Sorry, I'll bring him back.
It's like we've taken
Here's
4
all 4
stones
so
out,
far.
which is what I thought we were. Yeah.
Are you able to
But-
see it?
Yeah, it's pretty good, team. But
I mean, Jay,
Yeah.
We just say that.
that looks like what was on the Dyna, on the cone. beam.
correct,
Right.
correct.
But what are we looking
So maybe
at
some of these
on
are
fluoro?
radiopaque.
No, I
Beads.
guess Stu's making a good point.
What
I think
about
there's
another
more.
Dyna?
There are non-radio.
They were non-radiopaque.
Yeah.
I think there's just a lot of non-radiopaque stones.
Yeah.
All right, we're gonna try.
So I
these
guess,
endobronchial
you know,
forceps.
What, Jay? What would be our endpoint? You know, is it the radiopaque stones? Is it
It
doing
was,
another
I-
cone beam
that's what I'm-
CT? You know,
Right, but the cone beam showed 5. Yeah, I guess
Yeah.
at some level we have to decide if
What about? Do you just have
There's more to-
your fluid pouring out the sheath as you're pushing in? As you're
Yeah, and there's some gravel. Not really. It's more like
What if you got past the stones and injected fluid
Yeah.
beyond them and pushed them
put-
back out?
yeah.
Is there a
it's-
way to do that?
Like just flush them out. Flush them out the hole.
Just flush them out. You know, Ray did
Oh,
a
I
case,
Turn your.
Yeah.
another one
I
of
don't
these
see the
big
scope,
stone
right?
cases, and they got
There it
bilateral
is.
access
Can you
left and
close it for a
right
second?
with big sheaths, and pretty much pushed and flushed and broke up stones from one side and flushed them out the other side, so that they didn't have.
Okay, open
You know, when you
open.
only have one access,
Grab.
you have
You
your
feel it?
scope
Mhm.
in.
All
Uh,
right, open.
and they were able to
it's-
flush
You have to hold
one
on
side to
tight.
the other
Holding.
with a huge. Oh, that's
I'm gonna
working.
take both of these things out.
Ugh.
Oh, I won't fit in.
I might have to take the sheath out with it.
I'm not even sure if it's gonna come all the way out with the sheath even.
Okay.
And close.
Closed.
coming. It's coming.
Oh
No,
man.
it's like not grabbing.
I think it's just gonna pull it
Pull it.
down.
Yeah.
Yeah. I mean, the other thing is, I guess, where's that? Did I drop it? No.
You have it, Toyin?
So-
No, not well.
Okay, hold
There
on
we
one
go.
second. Close for a
So
second.
basically, Stu, you were saying having two accesses
Open.
into the same cavity so you can kind of inject through
So
one
like a
and
lavage and.
Okay. I
yeah,
have it.
yeah,
Yeah,
and
push
kind
it
of
out the
swirl
other.
everything about, yeah.
Open.
Just
you have
because
a
you don't lose that space from the
Close.
scoping in
Kinda
there
like
and
flips around.
Hold on one second.
And it's also your
Pull it back.
when you have the two axes, the flow is your.
No.
It's like
I don't
creating a
think you're on it
river,
anymore.
Mhm.
Yeah,
pushing
it's like
everything
kinda
downstream rather than having one access where you're trying to pull everything out. So it allows you to push. I mean, a lot of we've historically had success with biliary stones by pushing them out, right? Snaring them has always been hard, but we've been able to break them up and push them, break them up and push them. Pushing, I think, oftentimes is
I don't have a good
Open
grip on
again?
them.
easier, or more effective, or can be, than trying
Now
to pull everything
close.
out.
Closed.
Yeah. You're close?
Yep, I'm
You
close.
feel it?
Mhm.
It's a big
she's
ass
got
stone.
it.
Yeah.
Is it coming?
It's
think it's
gonna
too
get
big.
stuck in the sheath.
Yeah.
Yeah, I might have to
Gonna
pull
pull
the
the
whole
whole
thing
sheath
back.
Pull back.
I'm gonna pull the whole sheath back.
Oh.
Yeah, it's too
Yeah.
lost
Good.
again.
lost
What's
it
that?
again.
It's too. It's
too-
either stuck up against the wall.
Well, I think my sheath it hits the sheath, and so I need to be better.
So you think
about-
it's too big for the sheath? Or
which is surprising.
Well,
I mean,
it's
that's
too, or
another
your
thing. Like some of
forceps
these stones may.
your forceps are too big,
Whoa.
right? Like your open forceps aren't fitting
Yeah.
through the sheath. So Jay, one thing I'm noticing is
Got it.
You got it?
look how wide those forceps are. Look
Yeah.
how open those.
Yeah.
Oh, I think I lost it again.
You lost it.
Yeah. we
Yeah,
lost it.
I'm gonna have to like try to pull everything out.
Okay.
Or
This is.
not try this.
Yeah. And we got 4, right? I think that was our goal.
Yeah.
so is
going into
the
this.
Open here.
when I'm looking at the fluoro, is the issue that it's not coming into the sheath, or are they adhered to the wall of whatever
not-
cavity?
Here,
it's
I got something.
I think you got that one.
Hold on, let me take this out first.
Yeah.
I got one.
I'll take the umbilicals.
with the
I
basket,
think Toyin sort of
Rahul?
blunt with the basket. Yeah.
Because you're dissecting them
Toyin's-
kind of off the wall and then being able to kind of put them in the basket.
I think
Whoa.
that's
Yeah,
the
the
first
big one.
video
It's
page we got.
huge. Yo, this one's huge.
Make sure you show us. Oh yeah.
Can you see it?
That's crazy.
That's a good centimeter
Oh
plus.
my
for-
god.
That looks like a nidus of infection right there.
Yeah, right?
Yeah.
All right. Do you think the forceps like snared it out?
I
freed
think
it
it
up?
loosened it, and then
Yeah.
because that's one
I
of the
know we're grabbing
5,
it.
right?
Yeah.
Now we have 4.
Yeah, now
We have 4.
We've made
Yeah,
progress.
I think that's a good one. Kind of getting
made
them off the
fluoroscopic
wall. Yeah, getting them off the wall and then kind of picking them up with the basket.
I think, yeah, that
Oh,
was
you got another one there. Does it grab?
Yeah.
It grabbed?
I got
Grabbed.
something big.
Yeah.
Yeah.
Yep,
Damn it,
it's
Rahul,
grabbed.
you're the
We can
best.
see it coming in. Store that fluoro when you're done with this.
stored.
Rahul's my best
Thank
friend in
you.
the whole wide world, guys.
Oh,
I
yeah.
just thought of it like a.
Wow.
I just think of this like a claw machine.
Oh man, that one's a big one too.
It's the play till you win, you know, claw machines. Ooh,
It's pretty fun
was
to
awesome.
watch
Yeah.
too.
I think I'd be wildly frustrated.
Yeah. Very frustrating, but fun.
Now there's
You know, it's like
Now we're down to 3.
when you're a kid at the store and you see something and you can't have it. Maybe not even as a kid. Maybe my life now.
Yeah. My wife won't let me have a Nintendo Switch.
Yeah,
So.
the Switch 2 is coming out. And it's
Yeah.
like,
I kind of feel like you can try the forceps loosening and grabbing with the basket up there.
But these ones
I don't
don't
think
really
those are-
move, right?
That's what I'm saying.
Those
I
ones
think
aren't
it's kind
moving.
of they're kind of like
should we try to
yeah.
visualize them?
Yeah.
No.
I'm gonna come back.
Just kind
Oh,
of.
that one moved.
Did it?
The one that your scope is on one. You see it?
Oh, wow. Okay. Let me
Yeah.
pull back a little bit.
All right, let me unlock
It's
this.
kind of turned around a little bit here, to be honest.
I don't know
Oh,
why.
it's there.
Oh.
It's moving.
Okay.
Don't push it away.
Oh,
It's coming. It's coming.
Oh, that looks like progress.
Yeah.
Yeah.
I think if I pulled this back a little bit, let's see. No.
Where'd it go?
It's kind of towards
Yeah.
the left.
I'm trying
I'm
to turn
going
the
faster.
scope.
There we go.
Got it.
Great.
You are incredible.
So I think what's happening is actually
It's
what you're
stuck a little bit.
the radiopacity isn't actually the size of the
Can you
stone.
pull back? a little?
Correct.
Pulling. Yeah.
They're bigger
interesting.
You
than.
may have to
So,
pull the sheath.
I'm pulling. I got to pull the sheath here.
Yeah, and I think you got to pull the sheath.
It flew off.
It broke. Yeah,
Broke off.
you can see it there. It's right at the edge of the.
This is gonna be.
Yeah, now we're in an even tighter space.
Okay,
Right?
I just pushed
Oh,
it.
there you go. Yep. You're back in.
Yeah,
I
back
think
to
you
where it
have
started.
it. Oh no.
No, I don't.
But it's kind of now it's very mobile for sure.
Sorry, dude. Let me get this up a little bit.
So this is what I'm talking about. When you put a scope in, you learn stuff, right? So if we're just doing fluoro on this, you see that stone, and you think that's how
Yeah.
big it is,
You got it?
but it's
Yeah.
not.
Correct.
Yeah, it's
Correct. Good
definitely
point.
it's definitely bigger than.
So I think about all these times years
It
ago
actually-
where I'm like doing angiograms and trying to push stuff out and not understanding why it's not going out and why I have to keep dilating,
Here, I got it.
blasting,
You got it?
and stuff.
So I'm just gonna pull
This is
everything together. So
Yeah.
I'll get.
It may be bigger than the hole.
Yeah.
There you
I
go.
think you got it.
Yep, I think so too. Store that
Whoa.
fluoro.
That one's huge.
This one's ginormous.
Saved.
What is going on here?
Yeah. So as you can see, it's much bigger. I think we should stop now
yeah.
since we've lost access.
No, I can.
Well, we have the
we have a
safety
I
wire.
have my safety wire in. That's why I did the buddy. Can I have a?
So important learning point there,
Sheath.
Jay, right? You had your buddy sheath, your buddy wire. So if you have to
Yes.
take your sheath out because of the
Yes.
size of the stone, you don't
I'm
lose
a-
your access.
Guys, I'm a big fan of buddy wires, even when I get like PCN access or biliary
Here, so let me just show you.
access
These
from
are the
start.
stones we got. You can see like this is the last one we
It's
got. It's
huge.
very big.
To forget this little guy.
Yeah. So it was obviously bigger than the 30 French.
All right, can I have an Amplex wire?
Yeah,
Give it a
that's
college effort
So we
for the
got
7
the
so
little ones
far,
came
huh?
out easy. Yeah.
That's all. Every day is bad.
So when I go back to, I think,
So-
so as you guys were scoping, you were seeing a lot of stones, and I was noticing on the fluoro, you weren't actually directed at the radiopaque ones. So
Correct.
Right.
to me, there's a bunch
Yeah.
of stones in there that we can't see on X-ray,
Can you focus?
which
Oh, there.
makes me
Your
think
sheath's just way too far up.
you're going to leave some behind, right? Which is fine. Then the question is just when
Right.
do you stop? Because if you're going to leave some behind, how
Yeah.
many is? What's the point of
Give it a little bit more time of trying, a couple more.
You want to do more? Or I think those ones are huge.
Okay.
Also,
like,
how
just
many
given how big
stones
this one
did they
would?
actually get out with the gallbladder, right? These are a lot of stones to be dropped.
I know. This was done in
So-
a different country, so I don't
so
have the
Jay
opera
kinda-
what exactly what happened.
Jay, kind
Yeah.
of for the sake of time, I'm going to go back to Stu's
Yeah,
question.
yeah.
So what's your plan now? Are you going to go back in and try
I
to
think-
retrieve more?
Maybe I'll just do another pass with the Spyglass and see what things look like,
Yeah.
just for completion's sake. And then I think to your point, I think there's a combination of radiopaque and non-radiopaque stones.
The ones that are radiopaque are way bigger,
They're
even
way
on the Dynasty T shows, right?
Yeah, and I don't want to break them up because I think you're just gonna have more drop stones in a different place that I can't control. I'd rather have
And then-
a problem that I know of than create more havoc.
Yeah, and then once you get to that stopping point, are you going to leave a drain behind? And then what would be kind of the
Yeah, I'm
follow-up
gonna-
and
I'm
the
gonna
management
leave
for
a-
that?
We just need that wire.
I did need that wire. I will leave a 16 French drain again, and I will talk to her about next steps. Ideally, she would like to be drain free. So at some point, we need to either just like go drain free with a couple
got it.
stones in and see how she does.
You got it.
Because that's the lifestyle that she wants to live.
Stone free,
Well, she might not be stone free, but she'll be tube free.
tube free.
And then-
hopefully getting all these stones out would be helpful for her, you know?
Jay, let's just say
30,
you
got
take
it.
all
Yeah,
the stones out
yeah,
And I just kind of want you to give people a timeline. So you take all the stones out, you place a drain. When do you see her back, and when is it okay to take that drain out, assuming complete resolution of infection?
Yeah, that's a good point. I would downsize the drain today if I was confident that I was getting everything. So she would have a take everything out. I would put like a 12 French drain in and leave her. I'd see her in 2 weeks in the office. I'm going to give her antibiotics regardless today for 5 days and see her in 2 weeks, see how she's doing, see what the output is. And then if she's doing okay, I would schedule her to take the drain out, actually. Just go from 12 to, I don't think there's any extra benefit of going down to 8 and extending this. We're not treating anything. That her tract is going to heal with time. Yeah, I mean, biliary drains, these types of drains are just a real quality of life issue for patients. And
Yeah, they are.
Check the
They
wire out.
are.
yeah, now that we're done some therapy, oh man, these stones are moving now.
They're
Yeah,
moving,
these are
but I think
moving
they're just
fast.
huge, right?
Yeah, like
You see them?
Are we down to 2 radiopaque stones?
they're right there. Yeah.
Yeah, but are we down to
Look at
2?
this one. We're
Two
down to
radiopaque
2.
ones.
Yeah, 2 radiopaque ones.
So let's try the basket. We got decent.
I would feel really good about myself if we got the radiopaque ones out.
the ones you can see.
The ones we can see
And then are you going to plan to do a cone beam CT once you're done to kind of
at the end.
see how it correlates?
But, interestingly, the cone beam CT showed us 5, at the beginning.
Correct.
And we already have 7. So I don't know who to trust anymore.
Oh wait,
I can see them back
can
to
you grab
back.
this one? Yep.
You can
This
see
thing's stupid long.
they're next to each other.
I'm not used to.
They're in a row.
No, that's that one. Take that one away.
Yep. Somebody should make a stone
Seems
mat.
like you guys have done something to free them up a little bit, and you're like getting them. I mean, it sounds great. I would debulk as much as is easy, right? And then when it starts getting like harder,
Crazy.
maybe that's when you think about like, okay, am I doing more damage than good?
I mean, yeah.
But they're moving now. Before they were not moving like that. Before they were
Correct.
wiggling.
Yeah. Move my camera in a little bit more. Want to get that proximal one or the distal one?
I'm just trying to see whatever I can. The proximal one, right?
Yeah. It's moving with you, dude. It's wild.
Yeah, but I think it's like huge.
Yeah.
So, I think,
Oh.
that would have been, I just want to keep watching, but for the sake of time, I think we have a plan. You're going to keep trying to get those stones at some point. They seem like they're coming, so I'm pretty sure you're going to end up getting these out, followed by a drain and outpatient follow-up. Stu, any kind of last words of wisdom or any take-home points before we head out?
I mean, I've not done something like this before, so I don't know how many words of wisdom I can give, but I think the idea, nice job.
I'm going to take it all
So
out.
I know.
What's I think cool about this is noting how much bigger they are than even the cone beam would suggest.
Wow.
And I think we can apply that to everything we're doing when it comes to stone work, whether it's in the biliary
Rahul,
tree
I
or
ever
not.
told you you're amazing.
All I'm doing is just doing
Yeah, I
this.
think.
All I'm doing is this.
No, you are
And
the
I
best
think,
friend.
That's
I
another one.
think, Stu,
That
you
one's not
brought
as
up,
big as the
yeah,
last
that's a
one.
good
Yeah.
point, right? How much bigger they've been that we can actually see on imaging, how there's some we can't see on X-ray that we can actually see with the scope. So the value of having the spyglass and kind of the extra information you can get from it. So congrats on taking that other one. You have 1 radiopaque stone to go. For the sake
We're
of
gonna
time,
get it.
Jay.
We're gonna get it, guys.
I know you are. I know you are. For the sake of time, I'm just gonna any last words? Stu was just talking about the value of the scope and kind of understanding that the stones can be larger than we're actually seeing on X-ray or even more. So Jay, I'm gonna let you have the last word before I finish that in peace.
Thanks, Stu, for joining us at 6 a.m. in the morning on the West Coast while your daughter's getting ready for school. Appreciate it. I think Spyglass has a lot to offer for patients, especially now that we can go this way. I think the learning curve I think we're all talented people. We can all learn and figure things out. And if we just build a community that communicates about it, I think a lot of these patients that suffer with chronic tubes, I wouldn't want my family member to suffer from it if we had the tools available to kind of get rid of it. So I'd encourage people just to get used to it. I think something that helped us, we were scoping basically a lot. So even patients post liver transplant that had chronic tubes for biliary strictures, we were scoping them. We were using catheters to ablate, and we had really good success of getting people tube free. So I'd encourage people to at least try it out and get comfortable and talk about it more. And a lot of things are possible.
Awesome. Well, Jay, thank you so much. Rahul, Toyin in the room, and all our nurses, anesthesia, our techs. Stu, guest of honor, thank you so much for being here, even though it's very early, and for your input. It was certainly valuable. And then again, thank you everybody for joining, and we'll see you next time at Treat Live.
Thanks, everybody.
Send me
Thank you.
pictures, man.